Again, my name is Muriel Ang, and I am the project coordinator at the Ontario Neurotrauma Foundation. ONF supports the fall prevention community of practice and its online platform called Loop. Loop is a place where fall prevention practitioners connect. Visit us at www.fallsloop.com. Helene Gagne also joins us on the line. Helene is a director of the injury prevention at the Ontario Neurotrauma Foundation. She will be assisting us with facilitating questions in the chat box today. Before we begin, I'm going to give you a quick rundown on the Level 3 meeting system. This webinar technology consists of two parts. The audio is provided through a telephone conference line, and the visuals are provided through a web platform. The phone number for the teleconference line and the link to the web platform were sent to you by email after you registered for the webinar through Level 3. If you have any questions about the technology at any time during this presentation, please type them into the chat box on the left-hand side of your screen. Alternatively, you can email me at Mariel, that's M-A-R-I-E-L, at onf.org. I will work with you to resolve technical issues as soon as possible. This webinar will contain opportunities for participation. There will be online polls throughout the presentation where you will answer directly on your screen, and a question and answer period at the end. If you have topic-related questions during the presentation, please type them into the chat box. During the Q&A session after the presentation, questions will be read aloud to the group. If you would prefer to ask your question over the phone, we will provide the instructions to unmute your line during the Q&A. The webinar is being recorded, and a YouTube link will be sent to all participants in about 1 week along with the presentation slides. I would now like to introduce to you our presenter, Schroder Sattar. Schroder Sattar is a registered nurse and a doctoral candidate at the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto in Canada. Schroder's research focuses on falls in the geriatric oncology setting. For her doctoral dissertation, Schroder has recently completed a study that examined the circumstances and impact of falls and how falls are assessed and managed during clinic appointments. Schroder has previously published a systematic review on falls in older patients with cancer. She is currently collaborating with experts in North America and Europe to deliver clinical recommendations for nurses concerning fall assessments and interventions. Without further ado, please take it away, Schroder.
Hello, good afternoon, everyone, and thank you, Marielle. So as Marielle mentioned, today I'll be talking a little bit about my study, which basically looks at how falls are assessed and reported in outpatient oncology clinics among older adults, and also how falls might impact older patients' cancer treatment. So before we start, just like to do a little poll in terms of what sector each of you currently work in. If you would like to. Okay, looks like we have 5 of you working in the home care setting, and 2 in the hospital. I believe in more like an acute care. 7 in home care, and 2 of you in long-term care, and a few others in other settings. Okay. Looks like we have quite a diverse group today. Welcome again. Okay, so I would like to provide you with just a little bit of background in terms of falls. As you all know, falls are a really common concern among older adults. At least 1/3 of older adults who live in a community will fall each year. And according to the U.S. Centers for Disease Control and Prevention, every 17 seconds, an older individual will be experiencing a fall and subsequently will have to go seek care in the emergency department. And falls in older patients with cancer are of an even bigger concern, and it could be a number of risk factors that actually place them at higher risk for not only falls but also fall-related injuries. And I'd like to get your take on this. So what do you think may be the risk factors that are unique to the cancer setting that would place them at higher risk of falls and injuries? If you could please type your input in the chat box. Pain, yes, absolutely. Polypharmacy, cancer treatment, weaknesses, yes, frailty, and interaction of medications. Because neuropathy, yes, peripheral neuropathy as well, cancer treatment, and all of the above are correct, because cancer can not only place them at higher risk of falls, but also injuries, because number one reason, as we all know, fatigue from the treatment, depression. Say, for instance, when someone is on chemotherapy, they can be experiencing myelosuppression in terms of anemia, neutropenia, and also thrombocytopenia, which can place them at high risk of falls. As you all know, anemia is directly related to, sorry, my slide is not going. Okay, there it is. And anemia is directly related to fatigue and also neutropenia, which can place them at high risk for infection. And if somebody is hospitalized, obviously there will be deconditioning, which place them at higher risk for falls and weaknesses that are related to falls, and also thrombocytopenia. If someone who has a tumor, and if they fall, they can actually place them at risk for catastrophic hemorrhaging. And actually, I have spoken to a patient who had a tumor in his stomach, and he fell off the ladder, and that led to a chronic hemorrhaging, which so now he's on regular blood transfusion because of that. And obviously, radiation therapy, in particular, those kind that target the pelvic region or the abdominal region, can really affect the bone integrity of their pelvis, which places them at higher risk for bone fracture if they do fall. And someone mentioned peripheral neuropathy. Obviously, it's related to the many types of chemotherapy treatment. Chemotherapy and radiation therapy can also lead to mucositis, which irritates the GI tract, and a lot of times they have difficulty drinking and swallowing, and also diarrhea, which again lead to volume depletion and affect the blood pressure and place them at higher risk for fall as well. And then there's the bone cancer. Obviously affects the bone integrity directly, and bone metastases. And for older prostate patients who are receiving androgen ablation, those medication actually can cause loss of muscle mass and also osteoporosis, again placing a high risk for falls and injury as well. So why is this important? We all know the population is aging. The baby boomers start turning 65 in 2010. And since cancer is an age-associated disease, and because age is the number one risk factor for developing cancer, so as the population continues to age, the amount of patients and the concerns for falls and its consequences will be a really big issue confronting the oncology care teams, including doctors, nurses, and other allied health providers. I have recently conducted a systematic review which found that the fall rates in community-dwelling older adults with cancer can be as high as 78% over a course of 3 months. And also, older patients receiving a mixed agent chemotherapy, that is at least more than one type of chemotherapy in the same regimen, they are more at risk for injury as falls. And some of the significant predictors for fall-related injuries, including advanced age, advanced cancer type, and presence of osteoporosis. And again, older prostate patients receiving androgen deprivation therapy treatment, they tend to have more falls and fall-related fractures compared to older patients not receiving ADT and compared to healthy older adults. The same systematic review also found several gaps in knowledge. First of all, there's very few data on circumstances of falls, meaning how falls happen, what's the environment like, what are the circumstances, and also there's no data on how falls are assessed and managed in outpatient oncology clinic, and there's also no data on how falls can impact cancer treatment in this population. And therefore, what I found in the systematic review actually informed the research questions for this study. So number one, what is the circumstances of falls in this population? And what is the level of fear of falling in the post-fall context for these patients? And how fall impact their cancer treatment? and how do older cancer patients report falls when they do come in to see the oncologist, and how do oncologists assess and manage falls. And the last thing I explored was, from the oncologist perspective, how forthcoming are older patients in terms of fall reporting. So this was a conversion-parallel mixed method study design, meaning some of the questions were answered quantitatively, some of them were answered qualitatively, and some were answered both quantitatively and qualitatively, and they were happening at the same time. This is just an overview of how data was collected from the perspective of each research question. So the biggest part of the data collection was patient self-report survey, and which is sort of embedded with a patient open-ended interview, which happened at the same time after they have seen the oncologist during an appointment. And there was also a short review, basically just to look at some of the background information and also the medical and treatment history. And the last part was the oncologist interview. So for each patient who participated in the study, with their consent, their oncologist, basically their primary treating oncologist, because sometimes they might have several, the oncologist was invited to provide his perspective of the fall assessment, how they assess fall and manage falls, and about the patients reporting falls. And for those patients who had experienced injuries from their falls, the oncologist will also ask how those injuries might have affected the cancer treatment regimen. So the sample size of the study was 100. I recruited community-dwelling adults aged 65 years or above. So basically, any cancer site except brain tumors and those people who had brain metastases and who had experienced at least one fall within the past 12 months and who had at least 6 months of life expectancy based on the oncologist assessment, who were able to communicate in English and had no significant cognitive impairment based on the oncologist assessment. So for about 12 to 13 months, I was quite a pesky person on the unit because I actually had to approach the clinic staff, including the doctors and nurses in the medical radiation oncology clinics, and also something called the Older Adults with Cancer Clinics that runs in Princess Margaret Hospital every Monday and Friday. So I would ask them if there were any patients on that day on their clinic list that would fit the inclusion criteria. And for those who fit the inclusion criteria, I would ask the clinic staff to ask the patient for their permission for me to approach and explain the study. And also I placed flyers in the waiting areas in the oncology clinics and chemo daycare area just to capture patients who might not have been noticed by the oncologist or the nurses about in regard to the fall. So this was an exploratory study. So the quantitative data was analyzed through descriptive statistics, and then the qualitative piece was analyzed through thematic analysis using the Braun and Clark 6 steps of thematic analysis. So results. And this is what I found. So first of all, 100 patients were recruited. Response rate was pretty good at 92%. So actually, there were 109 patients that qualified for the study. One was deemed unfit by his treating physician, so it was not invited. And the other, they were already in another study or they were not interested. So out of 109, so 100 participated, which is really good. The median age was 76 years old, and the oldest participant is 95 years old. As you can see here, about 2/3 of them were male because we had quite a lot of prostate cancer patients. The majority of them were quite well educated with college and or university education. About 20% lived alone, and more than half of them had at least one functional limitation as measured by the instrumental activities of daily living. And predominantly, they were in advanced cancer stage 3 and stage 4. And as I mentioned, 1/3 of them were prostate patients. So basically, this is a busy chart, but as you can see, 44% of them had reported or recounted one fall during the study for the past 12 months, and the rest, which was over 50% of them, had recurrent fall. So by definition, recurrent fall means, as you all know, is having more than one fall within the past year. And the highest number of falls, this patient experienced 27 falls, and the most interesting thing was his oncologist did not know about it. So of the 100 participants, 168 falls were recounted during the study, meaning because obviously some of them had more than one fall. And the injuries fall rate was 45%, and more severe or serious injuries such as bone fracture and head injuries about 13%, which is quite high compared to the numbers in the general geriatric population, which ranges from maybe 1% to 10%. So answering research question 1, the circumstances of fall. The majority of the falls happen indoors, mostly at home. About 36% of them were at home. And as you can see here, bathroom falls were quite common, also in the living room. And a lot of them happened on the staircase as well. And in terms of outdoor falls, about 9% of them happen on the sidewalk curb when they were trying to get on or get off the sidewalk, and most of them involve tripping. In terms of activities, most common activity was walking, which is quite similar to what they found in the general geriatric setting, meaning the non-cancer population, and also change in position, going up and down the stairs, negotiating a step or a curb, and also turning. And of those who were normally using a walking aid, meaning a cane or walker, more than 1/3 of them fell when they were not using that walking aid. So some of the key themes from the interview, patients talked about bad turn, which is quite common. There's actually a recurring theme that a lot of patients brought up. That someone said, I just turned around and went down, and another patient said, I don't do turns very well. So another common thing that they said was not lifting the foot high enough and tripping. And one patient said, I just tripped on the stairs because I didn't lift my foot high enough and I tripped on the stairs. So this is quite common on not only the stairs but also curbs or little steps. One patient actually had that happen to him when he was at his cottage, and there was only 2 steps up to the front door, and that's when it happened. And also blaming themselves is also common. They tend to attribute the fall to their own mistakes or being silly. And one patient said, I thought it was a stupid thing on my part. And another patient, she said, I was rushing to go over to my brother's house, so dumb. And so she was actually reprimanding herself the fall. Another key thing that came out from the analysis of the qualitative interview was opportunity for education, because reluctance to use their walker or cane was quite common. One patient said, I didn't want to use it. I felt I could walk okay, but when the leg gives out, it gives out. We can do nothing about that. And another patient said, I don't need nothing. And she was actually arguing with her daughter about the utility of the walking aid. Now, this is the voice of a spouse, and so she was saying 5 weeks ago he wanted to go feed the birds. He wanted to walk out, and I told him, look, it's icy out there, but no, he had to feed the birds, and so he fell on the ice. He took 2 steps from the door and fell on the ice, so that's a lot of stuff he doesn't reason. So this is obviously another piece that is important for education, and this is not the only so-called risky behavior. We also have actually I've talked to patients who had, like I mentioned earlier, the one who had a tumor bleed, he fell off a ladder. One climbed on a high stool to reach something on a high shelf right after coming home from the hospital from the surgery. There was somebody who actually felt dizzy the day after chemo and decided he wanted to go ride a bike, things like that. So question 2, level of fear of falling in a post-fall context. So the fear of falling was measured using the Fall Efficacy International Scale and with a cutoff of 23. So based on this cutoff, more than half, 55% of the participants had high fear of falling. So in terms of the theme to go with it, being extra careful was common, and also taking up strategies. And this is how they perceive the fall is they need to be careful, and they are taking an extra strategy like slowing down, changing, a route to make things safer. And one patient mentioned that he still wants to go work out. However, he's enlisting a gym buddy to go with him. So reducing activities not common in this sample. Actually, a lot of the participants actually mentioned that they continue to stay active, or they want to be more active to keep up their strength. So, and this is actually different from what we have seen so far in the literature, which states that fear of falling can lead to activity restriction. So research question 3 about impacts of falls in cancer treatment. About 5 patients, which was like 7% out of the total calls that talked about, they had impact in cancer treatment. 3 of them had interruption of chemo, which was later resumed, and then 1 patient had his hormone treatment stopped altogether, and for 1 particular patient, his chemo dosage was reduced. So there was a discrepancy noted between the chart review and patient survey. So what happened was, out of the 5 patients who had impact on cancer treatment, actually only 2 recalled having interruption or impact on treatment, and the other actually said there was no impact. So this could have been due to recall bias, or maybe there was a lack of understanding of the treatment regimen or communication between themselves and the physician, or maybe it was just something else. It was just something they just forgot, because it's usually really stressful when they come into the oncology clinic and the day is really long, so maybe it was just a lapse in memory at the time of the survey. So in terms of cancer treatment, the impact of cancer treatment, so the 5 cases involved 4 oncologists, because 1 oncologist, he had 2 patients who had impact in cancer treatment. So I invited all 4 oncologists and only 2 participate. So what they said was, the impact on treatment for these 2 patients was minimal. It did affect them in terms of pain management, because as we recall, the majority of the participants in this study were in the metastatic context. So a lot of them, from the treatment perspective, the intent was more palliative as opposed to curative. So it didn't really affect the disease trajectory or the prognosis. Mostly it affected them from the perspective of symptom management. Question 4, reporting falls to oncologists. So from the patient survey, 168 falls are recounted. However, when I asked the patients, did you report the fall to your oncologist when you came in to see him or her next time? And only 72 of them said yes, and the other 72 said no, and the rest said they couldn't remember. So a key theme from for this particular research question is that a lot of patients felt that the falls is something that comes with aging, is really not important, and it's not really the oncologist's job to listen to them talk about fall. And one of the prostate cancer patients said, he is a cancer doctor, not a fall doctor. And like I said, not mentioning was another theme. And this patient said, well, like I said, those are minor incidents. This is really nothing or not much to talk about. And some patients actually said, well, they didn't ask me. And one patient said to me, you are the first person who asked me about falls. And so when I asked them, do you talk to your oncologist about the falls, I also asked them, did you talk to your clinic nurses, and did you talk to your family doctors? So the majority of them actually didn't tell the clinic nurse. And a lot of them also said, I didn't talk to the family doctor. And this is actually quite common. And one patient said, I spend my life in the hospital now, meaning the Princess Margaret Cancer Center. I don't need to see my family doctor. This is a busy graph, but basically just to provide an idea of not reporting falls to healthcare providers. You can see there are more people who didn't report than those who reported, and not telling the clinic nurse is actually the highest, followed by not telling the family doctor. And research question number 5 is how oncologists assess for and manage falls. Out of the 14 oncologists that were invited all together, not just for the impact of fall, but just to ask them basically how they assess and manage falls in oncology clinic. 13 out of 14 of them said they don't routinely ask about falls. And this is actually corroborated by what I found in the chart review, because only 11% of the participants' charts had documentation of assessment of falls. And out of the 72 falls that were reported to oncologists, only about 64% of them were actually documented, and the other were not mentioned in the patient's record at all. So the key things that emerged from this perspective is the necessity and feasibility of fall assessment. So oncologists, basically, they just felt that they didn't have enough time, and it's not something that is necessary to do so because there's just so many things to talk about, and obviously the cancer progression and the treatment and the symptom assessment usually is their priority during their clinic encounter. And one oncologist said it's not as the general routine. So if I have concerns in them about bone metastases or osteoporosis, I may pay attention to that. But oftentimes there are other things to discuss, so it may be one thing that I don't think about as often as I should. And another doctor said the issue is having the time to ask about so many different possible symptoms, which is fair. And in terms of fall management, this is actually what the oncologist says that they did when a patient reported fall. It's very close to what I found from the patient survey by talking to the patients, like in terms of what did the oncologist do when you told them about the fall. So asking circumstances and performing a physical exam and making referrals, and these are also the actions endorsed by the American Geriatric Society as well. And the last research question about oncologists' perspective of forthcomingness of falls. So the key theme is patients not fall reporting not forthcoming. So the oncologists would say they wouldn't report it unless we ask. This is actually the vast majority of oncologists saying the same thing. And when the subject does come up, they feel that the patients often minimize it and they don't really like to talk about it. Say, oh, there's nothing. And oftentimes it's usually the spouse who bring it up as opposed to the patient mentioning it. So we can see from about the falls in community dwelling older adults with cancer seem to be quite similar to those of the older adults who without cancer who live in the community, in particular with the circumstances of falls. So what the study has found was that falls were not commonly reported by older cancer patients to the oncologist. They were rarely assessed, and they could potentially impact older patients' treatment. And you might say 5%, that might be only a drop in the bucket, but considering the volume of older cancer patients that pass through Princess Margaret Hospital per year, 5%, we are looking at a lot of patients. We also found that a lot of falls were not documented, and another interesting finding is that older patients often they don't go back to see their family doctor, or some of them actually stop going back to see their family doctor once they have the cancer diagnosed, because they tend to regard the oncologist as their new primary care provider. So falls in this population could go unreported and under-recognized, and obviously, as we can see here, oncologists don't usually ask because it's too busy in the clinic, and older patients feel that it's not important to tell because it's a small thing, or at least they felt it's a small thing, and at the same time, they are not going to see their family doctors, and they are not telling the oncology clinic nurses, so obviously there is a lot of missed opportunities going on here. And also the reluctance to use their walkers or cane, it is actually quite similar to findings in the general geriatric population and may be linked to stigma associated with walking aids. And also attributing falls to external circumstances or blaming oneself could be associated with the notion of, I do not want to be seen as someone who is vulnerable to fall. So that's why we're seeing some patients, they will say, I'm foolish, it was a mistake, I was stupid. They would rather say that as opposed to saying, yes, I think I'm falling quite a bit nowadays. Maybe I am prone to fall or something like that. Some of the implications for research, obviously, this was only in one tertiary comprehensive cancer center, is by no means representative. in terms of the findings. For future studies, I can foresee more multi-site recruitment in different areas, capturing a more diverse population in terms of social, economic status, education, ethnic background, and also health conditions and so on. As we all know, usually the patients, especially older patients who get referred to big comprehensive cancer center for treatment, are the ones who are willing and able to be treated, meaning there are some older patients who may be more frail and have more comorbidities and health issues. They don't get referred to places like Princess Margaret. So I may not have captured, the full population here in terms of older patients. And obviously more than one data source because of the discrepancy in the reporting in terms of impact on treatment. And also more research is needed to examine the relationship between cancer treatment and falls itself, not just to provide more robust findings for the literature, but also to convince the oncology community that it is important to assess falls, even though we all know that it is important to assess falls. And in terms of clinical practice, it is really important to ask about falls during each clinical encounter. And it is busy in the oncology clinics, and we do know that they have really compressed schedules. But just by asking a simple question, did you have any falls since the last time we saw you, could be a really simple and important start. And health teaching is important, especially riskier activities within the context of having cancer and receiving treatment and having all those side effects from treatment and worsened bone mass and muscle mass. And also advice on techniques to how to fall safely. And exercise promotion, and obviously this has to be done along with follow-ups and assessment from PTs, OTs, and if someone who has cardiac issue, obviously the cardiologist, and something so that they can have a more tailored regimen to start with something moderate. And be mindful of language when we talk to patients about falls. And as you can see, some of them do not like to talk about falls. Maybe they feel embarrassed, or maybe they just don't like the notion of viewing themselves or being viewed as someone who is vulnerable to falls. So when we're talking to patients about falls and we're trying to promote exercise or promote fall prevention, it's better to use words such as strength training, maintaining the strength, maintaining balance and independence, as opposed to fall risk or prone to fall, things like that. Probably is not going to work very well. And another thing is, some of the gait and balance tests, like the timed up and go test or the gait speed, they literally take only seconds to administer. And so the clinic nurses can actually take this opportunity. Usually patients, when they come in for appointment, they sign in at the front desk, and there's going to be an hour's worth of sitting in the waiting area before they get summoned inside to, in the examination room. So that could be a really good time window to perform these simple tests, just to get an overall idea of the person's gait and balance, if they might have walking difficulties, if their mobility has worsened since the last time they came in. Because for those people who are on cancer treatment, especially those who are at the beginning of the cancer treatment regimen, usually their functional status or their mobility can deteriorate quite quickly in a matter of just 2 or 3 weeks. So it's really important to look at that or assess that more frequently. Exercise and physical activity. So again, the intensity of activity recommended should be taken account based on the person's aerobic fitness. So assessment is important. And the best thing is to recommend activities that can help maintain and increase their flexibility, which can actually help them in terms of their reflex if a fall is underway. And also, as I mentioned earlier, moderate intention aerobic activities, strength training, and also risk management and balance exercise for those who are at risk of falls and for those who may have recurrent falls. So for the next studies, I plan to use mixed methods approach to look at older patients' knowledge or their awareness regarding their increased risk for falls and injuries within the context of having cancer and undergoing different forms of treatment, and also to explore their perceptions about using walking aid. I also plan to conduct a multi-site examination of impact of falls in cancer treatment. As I mentioned earlier, one cancer site is definitely not going to be generalizable to the entire population. and a lot of impact on falls might have been uncaptured. So I plan to look at them in a more in a broader geographical area, and also in different cancer centers and different settings as well. And also I plan to conduct a pilot intervention study just to look at how effective it is to prevent falls and injury when you incorporate tips on how to fall safely to older patients, or especially those who fall recurrently, to incorporate these teaching into existing strength training classes. So just to wrap it up, obviously more research is needed to examine the impact of falls in this population and so much more. And hopefully the results of the study could help increase the oncology team's awareness of the importance of fall and fall assessment. And also hopefully it can help just to inform the beginning of thinking of maybe not developing anything yet, but just the planning of how to devise specific fall safety guidelines and education interventions and some of the support care services for older patients with cancer who live in the community. So these are some of the community resources, or actually what is going on currently. And as Mara mentioned earlier, I'm currently working with the Nursing and Allied Health Group of the International Society of Geriatric Oncology. We are trying to produce a summary of recommendations for fall prevention and management based on the most recent systematic reviews, and also fall safety guidelines by people such as the American and British Geriatric Society, by the U.S. Fall Prevention Task Force, and by the RNAO, and so on. And also the RNAO also has a new Preventing Falls and Reducing Injuries guideline that is new. And in terms of fall prevention program in the community in the Toronto area, in the Toronto Rehab Institute under the University Health Network, actually they have this exercise program that I think is a fall assessment on Monday afternoons, and then they have exercise education, fall education and exercise classes. They have 3 different groups that run at different times of the week. I believe it's Tuesday, Wednesday, and Friday. So this is something that could be useful for referral of older adults. So I hope you find today's presentation informative, or maybe a little bit helpful in understanding about falls, especially for those older adults who have cancer or receiving cancer treatment. Thank you so much, and I'm really glad that it's somewhat useful, at least to a certain extent. And you could please let us know what other information you would like to receive, and we would definitely organize that. And another thing is I would like to mention is that we have a virtual handout prepared. I believe that you might have received it in your email. It's basically just there are some articles on falls in older adults with cancer, so just to help you understand a little bit about on the context and about incorporating fall assessment into cancer care. So actually some physicians have actually written about it, and they are hoping to wrote it out, and not in an official way, but try to convince oncologists that it's really important to assess falls, because sometimes falls not only is an outcome, but it's also a symptom that can actually affect the patient's cancer treatment. Not as an outcome, but something that might speak to their frailty or their functional status that can have a really profound impact over the disease trajectory. And also and within the handout, you will see 2 systematic reviews, and actually they were done quite close to each other and published in the same year, I believe, in 2016. So they looked at fall rates, fall predictors, and also among other things. And one thing is some of the fall predictors found in the systematic review, the fall risk factors are actually quite similar to those found in the general geriatric population. But the majority of the studies that were in the review were cross-sectional studies, so it's not something that you can call it as strong predictors. So in the second review that we conducted, we only looked at prospective longitudinal studies that looked at that assessed for falls prospectively, and we found that cognitive impairment and prior falls were some of the key predictors of falls in older cancer patients. Obviously, that there should have been a lot more, but it's just because of the number of studies that were done so far on falls in oncology, and also because of some of the quality of the study. So a lot of them were not included, and obviously more research is needed in that area. And also I have included a video, it's a YouTube video that actually talk about how to fall safely for older adults. So it might be something interesting to look at. So on that note, I would like to thank you for your time. And my apologies, and going back to the virtual handout, it will be sent to you after the presentation, so you should be receiving in your email this afternoon.
Perfect. Thank you very much, Schroder, for your presentation. I believe right now it would be good to move into our Q&A section. So if anybody has any questions, please feel free to type them into the chat box. Alternatively, you can also dial, I believe it's *7 to unmute your phone, and you can ask the question directly on the audio line. So we'll just give it a couple of minutes for people to type in their questions in the chat box. And to start, there has been a question that's already asked by Karen LaValle for you, Schroder. And Karen is asking, can you speak further in regards to falling safely, any of the literature, strategies, and best practices?
Yes, thank you, Karen. This is a really good question. I have actually viewed some of those videos and actually listened to some of the experts talk about how to fall safely. So generally, it's interesting. I can't demonstrate it right now because we don't have the demonstration, the video. But basically, how it is like you have to instruct a person to turn when they feel that a fall is already underway. They have to turn a little bit and try to slide to the side. So it's hard to demonstrate right now, but it is in that actually the YouTube video, and I think somebody also asked, Indigit asked, is the name of the YouTube video. Actually, it is actually on the virtual handout, so you will see it when you receive that in your email. And I believe it's prepared by the Baker Rehab Group in the States. I believe it's in Maryland. So yeah.
Great, thank you so much, Schroder. Another question that was asked in the chat box, have you come across anything in the literature around increased fall rates among certain cancer diagnoses?
Well, obviously, for cancer diagnosis, obviously those who have brain cancer or those who have other cancer but have spread to the brain, those people have really high fall rates just because of the neurological interference. And if we don't count this, because this is like something that will, for sure, you know that it will happen because by virtue of the site of the cancer. But other than that, older patients who receive hormonal treatment, and we're talking about prostate cancer especially, and breast cancer as well, they are quite prone to falls. And specifically for prostate patients, because of the androgen ablation they are receiving, that can lead to pretty dramatic decrease in muscle mass, which obviously would directly affect their gait and balance, and also the osteoporosis piece, which places them at really high risk for injuries as well. But in general, for older patients with cancer, they are at higher risk for falls compared to older adults without cancer because of the different types of cancer treatment and the direct and indirect impact of those, or the side effects of the treatments can place them at higher risk for falls.
Wonderful. Thank you, Schroder. I'll just give it another few seconds to see if anybody else would like to input any questions in the chat box. The chat box can be found on the bottom left corner of your screen, and you can type in a message there, and it will automatically broadcast it to us, and we'll be able to flag it as a question for you. So I'll just take some time, and if anybody else has any questions, please feel free to type them away. But I would like to thank our presenter, Schroder, for a wonderful presentation. I especially liked the suggestion of using time in the waiting room to conduct fall risk assessments. I think that's a very innovative idea that can be relatively easily implemented. I'm just looking in the chat box right now, and I'm seeing a question from Nita. Do you have any plans to pilot fall risk screening in the Cancer Center?
Thanks, Nita. That is a really good question. It's actually one of the things that I would like to do. And obviously, this is something that I have to do it in collaboration with the oncology team, including maybe the physicians and the nurses. So it's something, again, I feel that right now we need more research to try to convince the oncology community that it is important to assess falls. So I think the first thing I plan to do is to actually conduct study that can demonstrate there is a really huge impact on falls in this population, and also a study that can demonstrate a strong link between having cancer and being under treatment with falls and injuries. So that sometimes it's not that they are skeptical, but it's just that sometimes they are so busy. I would really probably require some really robust research evidence in order to do that. But yes, that is something definitely I plan to do in the future.
Wonderful. Thank you, Schroder. I think I also see a question or suggestion from Karen again. Who would do the TUG time up and go test in a waiting room, as often there are no health professionals available rather than a receptionist?
That's a good question. However, sometimes the nurses, when they actually go call the patient in and walk them to the examination room and take their blood pressure, that would be a good time, especially when we're doing gait speed and doing timed up and go. We need them to walk anyway, and the patient on the way from the examination room. One thing that actually what we did in another clinical trial is when we're trying to perform geriatric assessment for older patients in a cancer clinic, we did it while some of them were waiting for their appointment. We actually put tape, like duct tape, like colored tape on the floor and measured out, that 4 meters or how many meters that we need them to walk. So when the nurse actually walked the patient from the waiting area into the clinic room, that could be, they could just make them walk between those tapes and time them with their own phone or just a stopwatch. It's something that can be done within seconds. But it does take some, embedding of that into the walking patient in routine, but it's something that's actually doable.
Wonderful. Thank you, Schroder. Another question. There are various fall assessment tools that can be used in primary care. Is it that the oncologists are not aware of them?
I believe it's not that they are not aware, but it's just that sometimes in the clinic they are really busy, and they actually also mentioned it during the interviews that there's so many things to ask. They don't even have time to ask about falls. Usually they're just, how you're doing? Are you still feeling nauseous from the chemo? Are you having that pain? Is the radiation helping with the pain? So they usually ask these kind of questions. So they don't ask about falls. And obviously they would not have any time to conduct a fall or a fall assessment using tools. It's just a reality in oncology clinic. But but like I mentioned, there's a lot that the nurses can help do, or if they talk to the patient or they assess the patient and there might be a fall risk or some gait imbalance issues going on, obviously they can communicate that to the oncologist, which can trigger further assessment or referral. And one thing I know that is in oncology clinic, usually the oncologists, they use something called the ECOG. And that's for all cancer patients, not specifically for older patients. But unfortunately, this tool is not really sensitive in terms of picking up functional impairments in older patients. So So I would suggest that within the compressed time schedules in the clinic, they could start with something like the gait speed, for instance, and if they pick up something abnormal there, then further assessment referral can be done.
Wonderful. Thank you so much, Schroder. And I just want to say that I love all of these ideas and all of these different suggestions that are being made in terms of providing these fall risk assessments in these clinical settings. And I think this is a good time to just speak on our fall prevention community of practice Loop platform. I would highly recommend that if you haven't already joined Loop, please do. It's for anyone who has an interest or is passionate about fall prevention. You can connect with other practitioners online and ask questions. And we do have a discussion board, and I think it would be great if we could continue this discussion online on Loop and talk about some more of these innovative ideas to serve this special subpopulation of fallers. Also, there is just one other comment from Nita. If there are barriers to doing fall risk assessment in the cancer clinic, perhaps collaboration with primary care would be more valuable. And I think that's definitely a very interesting comment and very pertinent. Thank you, Nita.
Yes, thank you. I agree. And I think it's really important to encourage older patients to go back regularly to see their family physician, even though they are seeing an oncologist for the cancer treatment. Yeah.
Perfect. Excellent.
Thank you.
Perfect. And so if there are no other questions, I'd like to thank all of you for participating with us today and for joining us and engaging in such a great discussion. I hope the information that was gained from this presentation can fuel some further discussion in your practice and beyond around this unique and important subgroup of fallers. So with that, I think we'll be ready to sign off for our webinar. Please do not close this window just yet. However, wait until you have been redirected to the next screen where a brief evaluation survey will launch in your browser. And we'd really appreciate it if you could provide your feedback so we can continue to offer more high-quality webinars in the future. Thank you all, and have a wonderful day. See you next time.